Hello everyone, I'm Genesis Salvador and today I'm going to tell you a little about dapagliflozine and cardiovascular outcomes in type 2 diabetes. Type 2 diabetes. The term diabetes mellitus describes disease of abnormal carbohydrate metabolisms that are characterized by hyperglycemia. It is associated with a relative or absolute impairment in insulin secretion, along with varying degrees of peripheral resistance to the action of insulin. What is dapagliflozine? Dapagliflozine is a medication belonging to the gliflozin family of diabetes mellitus. It was approved by the FDA on January 8, 2014, with the indication of control of hyperglycemia in type 2 diabetes.
SGLT2 inhibitors explained in 3 minutes. Let's begin. The SGLT2 inhibitors, or sodium glucose cotransport 2 inhibitors, are one of the newer medications used to lower blood sugar in patients with type 2 diabetes. These drugs can be identified by their suffix gliflozine. For instance, dapagliflozine, or its brand name Jardiance, or dapagliflozine, or canagliflozine. So, how exactly do SGLT2 inhibitors reduce blood glucose levels? But firstly, what is SGLT2? Sodium glucose cotransporter 2 is a protein found in the nephrons of the kidney. Approximately 160 to 180 grams of glucose is filtered from the glomerulus into the Bowman's capsule in a day. SGLT2 is a protein in the proximal convoluted tubule that acts to reabsorb filtered glucose back into the blood. Approximately 97% of filtered glucose is reabsorbed into the body through SGLT2, and the remaining 3% is reabsorbed through another protein called SGLT1. As a result, very little glucose is excreted through the urine. As the name suggests, SGLT2 inhibitors, such as dapagliflozine, bind to SGLT2 and prevent the reabsorption of glucose back into the body. As a result, more glucose is excreted through the urine, and this results in a reduction in blood glucose. So, to summarize, SGLT2 inhibitors act to decrease glucose reabsorption in the kidneys, resulting in increased excretion of glucose in the urine, and this ultimately leads to a reduction in glucose. Additionally, this medication may also help with weight loss, and it is worth noting that SGLT2 inhibitors do not cause hypoglycemia. Looking at the side effects of SGLT2 inhibitors, urinary tract infections and genital fungal infections, such as yeast infections, are more common in patients taking this medication. This is due to the increase in glucose in the urine, which promotes bacterial growth in the urinary tract. Some patients may also experience increased frequency of urination, and this may lead to lower blood pressure due to the loss of fluids. Some patients may also notice a slight increase in their cholesterol values, as well as some nausea.
Application in medicine. Dapagliflozine 10 mg was daily improved glycemic control and reduced body weight and systemic blood pressure when added to usual background therapy in patients with inadequately controlled T2D and persistent CVD and hypertension.
Over the past 2 decades, several studies have highlighted the importance of intensive glucose-lowering therapy, blood pressure control, and statin use to reduce the risk of cardiovascular complications and mortality in patients with diabetes. But the long-term trends of mortality and cardiovascular outcomes of patients with type 1
or type 2 diabetes, as
compared with the general population, are unknown.
In a study of patients enrolled between 1998 and 2012 in the Swedish National Diabetes Register, a total of 36,869 patients with type 1 and 457,473 patients with type 2 diabetes were included, along with matched controls from the general population. The outcomes that were assessed were all-cause mortality, fatal coronary heart disease, fatal cardiovascular disease, and hospitalization for cardiovascular disease. The rate of all-cause mortality declined among those with type 1 diabetes by 29%, and in matched controls by 23%, a difference that was not statistically significant. The rate of hospitalization for cardiovascular disease decreased by 36% among those with type 1 diabetes and by 9% among matched controls, a decrease that was significantly greater for the diabetic group. The rate of all-cause mortality decreased by 21% among those with type 2 diabetes and by 31% among matched controls, a statistically significant difference that favored the control group. The rate of hospitalization for cardiovascular disease decreased by 44% among those with type 2 diabetes and by 29% among matched controls, a statistically significant difference that favored those with type 2 diabetes. The authors conclude that mortality and cardiovascular disease have declined for patients with diabetes. For most cardiovascular outcomes studied, event rates have decreased at least as quickly for patients with diabetes as for matched controls. However, as compared with matched controls, patients with type 2 diabetes had a smaller reduction in fatal cardiovascular outcomes. Full study results are available at nejm.org.
Pros and cons. The study cites that using both dapagliflozine and insulin has fat impacts, reduces body weight, prevents CVD, and improves quality of life. The study showed that dapagliflozine has a gastrointestinal side effects, risk of hyperglycemia, risk of genital infection, and a risk of developing diabetic ketoacidosis.
So my overall impression was that this trial, like other SGLT2 inhibitor trials, again proved that there is substantial benefit in terms of reduction of heart failure hospitalization risk. As you know, there was a split primary endpoint of this trial. The MACE endpoint did not reach statistical significance, but the combined endpoint of cardiovascular death and heart failure hospitalization did reach the endpoint, which was positive. I think it's adding in several ways. So one issue obviously is that it further reinforces the issue of safety. In this trial, at least, we did not see any differences in the risk of amputation. So that was answered. That was a big question that was in people's mind. The second question that was in people's mind was that this trial had the largest cohort of patients with risk factors but without atherosclerotic cardiovascular disease of all the SGLT2 inhibitor trials. So the question was there any benefit in the primary prevention versus the secondary prevention cohort? And then the third is just the overall body of literature regarding SGLT2 inhibitors in management of diabetes. So for these reasons, this is sort of the fulfills the picture, and that's another plug that you can put in the vast amount of literature we have. So the limitations of the trial are that, again, so this is a randomized controlled trial that included patients either with cardiovascular risk factors or with atherosclerotic cardiovascular disease. But a big proportion of patients with diabetes out there, shorter duration of diabetes, actually have no cardiovascular risk factors, and they were not included in any of the clinical trials per se. So that is sort of one thing that we have to be careful about. But other than that, all of these trials, what we're learning from SGLT2 inhibitors is that the primary endpoint of MACE, which was primarily defined on the basis of the FDA guidance, the benefit is restricted to those with atherosclerotic cardiovascular disease at baseline, and there's a modest benefit. But there's a bigger benefit for heart failure hospitalization and renal benefit that we are seeing in these trials that goes across both the primary prevention and secondary prevention cohort, which really makes you think whether the definition for primary prevention and secondary prevention, the way we define it for atherosclerotic disease, is really applicable for heart failure or chronic kidney disease. I mean, the biggest take-home message for the clinician is, stay tuned. We have now 3 drugs that is showing significant impact of this therapy in reduction of heart failure risk, which is one of the commonest complications of patients with diabetes. So as things work through the regulatory agencies and the guidelines, I would not be surprised that in the future, irrespective of the benefit on MACE, just for heart failure prevention, we probably will be using a lot more of these agents in patients with diabetes at higher risk.
show a plate in Ecuador. Originating inhibitors of sodium glucose co-transporter type used for the treatment of diabetes mellitus type 2 have demonstrated a cardiorenal protector effect. Experimental studies and different studies have established that the inhibitors SGLT2 reduce the progression of hypertrophic cardiomyopathy, fibrosis, cardiac remodeling, systolic diffusion, and heart failure.
Father would ask,
what have we learned about the mechanism of action of SGL2 inhibitors that explains the cardiovascular effects of Dapagliflozine?
It's a great question. I mean, to be honest, I think the results were surprising, and I don't think many people expected there to be the dramatic effect that there was. And so really trying to figure out why that was is really a little bit of thinking backwards and trying to understand the way the drugs work and therefore what it could do. So what we do know about SGLT2 inhibitors is they result in a little bit of diuresis and volume contraction, and that certainly could be one of the factors, particularly in terms of CHF incidence and hospitalizations for congestive heart failure, which they saw benefit for. There's also a small amount of weight loss, which could also be a factor. There was a regression model that took the data from EMPA-REG and tried to look at this. And again, to whatever degree you can believe that you can go back afterwards and do this kind of analysis. About half of the effects seem to be the volume related. And they uncovered another strong correlation, which hard to know clinically this makes sense, but it is at least hypothesis generating. So there seems to be a correlation with uric acid levels, and whether that's an explanation or an epiphenomenon is difficult to know for sure. So I think we have some theories as to why this has been effective, but it was a surprising result, and so we're left to try to figure it out.
So what do we need to go beyond those theories and try to sort of get that causal mechanism?
Well, I think study designs, as Dr. Azuki mentioned, that would tease that out. So either you're comparing it to another drug, or you're controlling things more effectively, and now being able to look at contributions. And I guess the other big piece of all of this, that I know we'll be talking about, is class effect or not. And if it is not a class effect, where you don't see the results corroborate, does that tell you something then as an indicator what the mechanism is?
So there's another finding of the Dapagliflozine trial, EMPA-REG, which is fascinating and may shed light on this. And this is the effect on renal disease. So another very important publication looked at renal outcomes, and it appears that these drugs are not just diuretics, but they act on sodium excretion very proximally in the kidney in such a fashion as to, in a certain sense, work in a lovely way with angiotensin blocking agents. So at the level of the macula densa, delivering more sodium to that part of the kidney seems to then potentiate the benefit of not having so much angiotensin action on board. Well, this fits very nicely into a lot of our clinical knowledge of what's good for heart failure and our theoretical ideas of what's good for the heart and what's good for the kidneys.
I think we really need mechanistic studies at this point to understand in retrospect what we found in this large clinical trial. It's really exciting, not only from a cardiovascular standpoint, but also from a renal standpoint, which is another scourge of diabetes is end-stage renal disease. And as Dr. Bloomgarden pointed out, there was about a 40% reduction in the development of the composite renal outcome in EMPA-REG outcome, which was a combination of doubling of serum creatinine, persistent macroalbuminuria, the need for dialytic therapy, end-stage renal disease, and renal death. And that was not driven solely by the macroalbuminuria, which some nephrologists feel is a softer endpoint than something quite hard, like the need for dialysis or doubling of serum creatinine. So it's really causing us to go back and trying to understand the physiology of the renal tubule. And as Dr. Greengarden pointed out, this may be a special, unique type of diuretic class because of the proximal effect on sodium excretion. Perhaps bathing the macular density in sodium can lead to an attenuation of the normal neurohumoral activation, renin, angiotensin, antidiuretic hormone, that could have counterproductive effects in particularly patients with left ventricular dysfunction.
And of course, we know that nephropathy is a major risk factor for cardiovascular disease, and so one could imagine a mechanism through which nephropathy is improved, and therefore also, because of that, lowering the risk of cardiovascular disease.
Conclusion. The results obtained from the use of dapagliflozine have been favorable, concluding that its use considerably reduced the risk of severity and improved the quality of life of patients with TF2 due to its hyperglycemic properties.
Farxiga is a prescription medication used to control blood sugar levels in people with type 2 diabetes. Farxiga belongs to a group of drugs that work in the kidney to block a protein called SGLT2. By blocking this protein, the drug can remove excess glucose, sugar, and calories in the urine, which then helps lower blood sugar levels. This medication comes in tablet form and is usually taken once daily. Farxiga tablets should be swallowed whole and can be taken with or without food. Common side effects of Farxiga include low blood sugar, yeast infections of the penis or vagina, and backache.